Good morning, everyone. Wins at ATS this week, so I'll be starting us off for grand rounds today. And today I have the distinct pleasure of introducing Dr. Scott Laurenzo as our grand round speaker. Dr. Laurenzo completed his undergraduate degree in psychology at Creighton University before completing his MD training at the University of Iowa. As you know, Scott completed his internal medicine residency training here at UW, where he was a leader in our teaching pathway and an active researcher with projects related to asthma severity assessment and imaging findings in pulmonary hypertension. Dr. Laurenzo will be continuing his training as a pulmonary and critical care medicine fellow at Northwestern, starting in just a few short weeks from now. Scott has been an exceptional chief resident, a leader within the residency program, a tireless advocate for the residency and our residents, and a talented teacher and educator. Today, he'll speak to some of that educational work as he highlights the important and growing role of simulation in internal medicine education. Please join me in welcoming Dr. Laurenzo.
Thank you, Andy. I really appreciate that introduction. I'm an avid podcast listener. I have my regular shows to catch up on each week or sometimes even each day. It provides a nice background to getting ready each morning or during my commute. Every now and then, there's a story, though, that catches my attention. It's no longer background. I have to stop all my other tasks to really take it in. This happened actually earlier this year with an episode of Hidden Brain. If you're not familiar, Hidden Brain is a podcast exploring aspects of human behavior and social science. The topics vary, but this particular episode, Work 2.0, Game On, really struck a chord. The guest, Ethan Mollick, discussed how games or simulations can enhance people's job performance and even satisfaction. It discussed plenty of examples, including using online games to crowdsource human creativity and problem solving into solving 3D puzzles, which were actually designed to help scientists discover how proteins may fold to varying effects. In effect, this game helped to crowdsource solutions to scientific questions from non-scientists. However, this episode also briefly touched on the use of simulation in high-risk jobs, such as airline pilots or physicians, where a single mistake can be extremely costly, but studies have shown that after 1 or 2 practice sessions, the rate of error is greatly reduced. This indicates the major potential benefit of correctly utilizing simulation. At the time that I heard this episode, I had already spent plenty of hours participating in simulation or even facilitating simulations throughout my medical education. In fact, I had already even begun collaborating on creating a new simulation product for the IM residents when this podcast came across my feed. But to fully understand the importance of simulation education and how it can be utilized in internal medicine training, I thought it would be nice to go chronologically through the first recorded use of simulation in medicine through where we are today and then beyond. For our learning objectives during this presentation, I hope that by the end, you'll be able to describe the progress we have made in simulation technology and its use in education. You'll be able to identify different forms of simulation. You should be able to describe areas where simulation has shown benefit within medical education, and then be able to propose areas where simulation should even be expanded upon within medical education. For an outline for this presentation, we'll start with simulation in the past, again, kind of exploring its historical roots. We'll move into the present and discuss some of the most recent studies that show how useful it can be and in what areas it can be used. We'll then narrow in to make it more relevant to us and discuss what does UW currently do, specifically within the internal medicine residency program. We'll then kind of extrapolate that into ideas on how it can be used in the future and what I would propose we do moving forward. And then we'll wrap up at the end with a few summary points. To start with some definitions, I really liked this definition of simulation from Karen Rosen. The first underlying portion is a standard definition of simulation, and then the second half is kind of how it's used within an educational purpose. So, simulation is an imitation of some real thing, state of affairs, or process for the practice of skills, problem solving, and judgment. I just really liked the full encompassing nature of this definition. A few more definitions. There's a few different types of simulation, which I'll reference today, that the vocabulary behind might be a little bit new to certain people. So within types of simulation, a task trainer is a simple or complex device, but it's usually focused on a single use. For example, a mannequin that you may use to practice intubation skills or CPR skills, or a synthetic skin pad that's used to practice suturing. A simulated clinical environment doesn't necessarily need to be physical. It can also be screen-based or virtual reality, but its overarching goal is to fully immerse the learners within the environment of the simulation. A standardized patient is an actor who's playing the role of a patient with a particular history or physical exam findings for a learner to assess and gather. These are commonly used for physical exam skills or communication skills. And then a realistic human simulator. This is the high fidelity mannequins that some of us have used. They can demonstrate physical exam findings, vital signs, and otherwise act as close to a real patient without actually being a human. And then finally, mastery-based learning model of education will be referenced many times throughout this presentation. It's the most common model used in simulation learning, and the main tenet is the fact that a learner must demonstrate an understanding of a topic before progressing to the next level of complexity or starting a new task. They cannot progress simply based on an amount of time spent in practice. They have to demonstrate knowledge and comprehension. Within simulation, this is sometimes used via a standardized checklist with a predetermined checklist threshold score for learners to be able to advance to further simulation topics, or sometimes be considered competent to perform a task such as bedside procedures. If they don't meet this threshold, then you would require further practice before reassessing. If you're more interested in, or if you're interested in hearing more details about mastery-based learning model and how it applies to simulation, I want to place a plug here for one of the chief resident grand rounds from last year. Katie Fell presented an excellent grand rounds regarding simulation-based education, including the details regarding its learning theory. I'm not going to go into detail about the theory very much today, but her grand rounds is still available to watch via recording on the grand rounds website if you're interested. So we'll start in the past. I want everyone to think to themselves right now to guess how many years ago do you think humans started practicing simulation practices for medical training? 50 years ago, 100 years ago, 200 years ago? What if I told you that there's documented simulation in medical education from more than 2,500 years ago? Sushruta was an Indian sage that's sometimes referred to as the father of plastic surgery. He was associated with a Sanskrit text from around 600 BCE describing various medical treatments and procedures, including how to simulate some standard procedures such as extraction of teeth from dead animals or cauterization on soft meat, bandaging on dolls. It even documents the first recorded observation that simulation-based education can lead to competence and confidence in this quote here. An intelligent physician who has tried his prentice hand in surgery on such articles of experiment as gourds, or has learned the art with the help of things as stated above, or has been instructed in the art of cauterization by experimenting on things which are most akin to the parts of the human body they are usually applied to, will never lose his presence of mind in his professional practice. Moving into the 11th century CE, China's imperial physician attempt to standardize acupuncture teaching, creating 2 life-size bronze statues made to teach surface anatomy and acupuncture points. It contained organs and even had 354 open holes for insertion of needles. It's proposed that they were covered in wax and filled with a liquid so that a drop of liquid could be found if a needle was inserted correctly. Moving into the mid-late 1700s, obstetric simulators became very popular throughout Europe and other regions of the world. These simulators included glass uteri in a pelvis or flexible fetus to train midwives and surgeons in childbirth. They were required to complete tasks blindfolded even at certain times. Similar models were developed out of various materials over time, including deceased patient tissue, leather, glass, rubber, and cloth. And interestingly, we already start seeing documentation of some of the critics of simulation, which actually even we sometimes hear today, specifically related to the idea that this is just practice and not real patients, which can lead to maybe false behaviors or incorrect behaviors. And again, the idea that using a soft mannequin is not as good as using actual deceased cadavers. However, even by the late 1760s, it already has its proponents. In this quote, we see from a letter of someone who had created an obstetric simulator saying, "A surgeon or woman who takes the sort of course available until now will learn only theory and will expect the situations to be uniform, or at least not very varied. But when difficulties arise, they are absolutely unskilled, and we have the advantage of students practicing on the machine and performing all the deliveries imaginable. Therein lies the principal merit of the machine." By the late 1800s, the US government is noted to endorse simulation education. In one chapter regarding intestinal suturing advice in the realm of warfare, they quoted, "It should not be attempted on the living subject until the operator has acquired some experience by practicing either using the fingers of a glove, or better still, upon a recent subject or on intestines placed in a mannequin." At the turn of this century, Killian develops the first direct bronchoscope and noted the need for practice on a simulator, mostly because of the complexity of the device and depth perception difficulties. It's interesting to note that then an article published almost 100 years later in the early 2000s, the authors were trying to theorize why high complication rates were present among new bronchoscopists, even just a few years prior in the 1980s. And one of their main citations was the possibility that bronchoscope training was still in early evolution, despite the fact that a simulator had been developed 75 years prior and practice was noted at this time. I like this story because it highlights how simulation technology and learning is sometimes seen as a recent discovery rather than something that's simply been overlooked. In 1929, the first high-fidelity flight simulator Blue Box appeared. It appeared like a fuselage and reproduced motions and sensations. It was a controlled and safe environment for pilots to practice high-risk conditions that they may only rarely experience. And this advancement in technology between the aviation industry sometimes would carry over into our medical field as well, regarding creating simulated environments and technology. In the 1960s, we had many different developments. Peter Safar advanced teaching of mouth-to-mouth CPR and worked with a plastic toy maker to create a realistic simulator that some of you may recognize here. It was initially created just to practice the chin lift technique, or else the airway would remain obstructed. But then Dr. Safar actually requested a spring be attached to the chest to simulate cardiac compressions. This is one of the most widely available and kind of famous task trainers. Additionally, in 1968, Dr. Gordon created Harvey, which was a mannequin designed to reproduce various cardiac diseases, including varying blood pressure, heart sounds, pulses. And studies from this time already started showing that medical students trained with Harvey performed better than their peers and had enhanced confidence and ability to interpret findings on a patient. And finally, in 1964, Dr. Howard Barrows created the first standardized patient session, which he called programmed patients, for use during a neurology clerkship. He had observed a patient become annoyed with repeated clinical examination by learners, and the patient purposefully changed his neurologic findings for the next doctor out of protest. But this gave Dr. Barrows the idea of creating simulated patient encounters with specific findings to be discovered. Over the next few decades, simulation became more and more advanced, and then in 1999, To Err is Human is released. It indicated a large number of deaths each year due to medical errors. In some more recent studies suggested 400,000 Americans die each year due to medical errors. This landmark report resulted in many recommendations to improve patient safety, with one of these being increased use of simulation to help practice critical event scenarios. Many studies since have discussed the role of To Err is Human in encouraging the development of simulation for patient safety. So, what is the current use of simulation in medical education? To start, what is our current medical education model? The apprenticeship model has been around for thousands of years at this point. The idea behind apprenticeship is that the trainees are exposed early to patients and pass through increasing levels of difficulty and autonomy. Clinical decisions are shared amongst all levels, although final decisions rely on attending experts. So then how do we integrate simulation, and why should we integrate in simulation, which helps give more autonomy to learners early on? To start answering this question, I tried to evaluate how active simulation education actually is in internal medicine education. However, I actually couldn't find any studies surveying residencies. Instead, I had to extrapolate the results from a 2011 survey asking internal medicine clerkship directors. Of 86 US clerkship directors in internal medicine, 84% said that they were using, said they were using a form of simulation, including most commonly standardized patients and mannequins. The same survey asked for the general purpose of the simulations, and 34% stated their goal was formative assessment, 27% stated teaching was the primary goal, and 36% stated summative assessment. So in totality, only 27% actually said that teaching was their primary goal, although of course assessments may be a portion of teaching too. A 2007 study in critical care medicine survey showed that of 289 internal medicine residents who responded, 49.3% of them felt inadequately trained to lead cardiac arrest teams. This is arguably one of the most important and critical roles of an inpatient internal medicine resident, especially in terms of it being able to effectively and efficiently respond to these situations. Additionally, 50.9% of them felt that ACLS course did not provide the necessary training for team leadership. And 40% said that the ACLS course is actually the only training they'll ever receive for ACLS code leadership. And remember that that's only given every 2 years. Finally, 55% worried frequently that they had made errors in the past. When asked what could be done to address these concerns, the respondents had very specific recommendations. They stated that full-scale simulation, leadership skills training, and post-event debriefing would be most effective in increasing their skills and confidence. So in short, residents currently don't feel confident in the baseline skills training needed to effectively complete one of the most stressful and critical aspects of their job within the inpatient world. And they specifically stated that simulation and skills training would help correct that. But is this actually true? Does simulation actually improve resident performance, especially during codes, for example? Various studies have been designed to study just this. This 2005 study by Wayne and colleagues randomized PGY2 residents between simulation training or no simulation training for management of common code situations. They were then assessed with a secondary assessment 3 months later. So they randomized 19 residents to each group where they took a baseline ACLS competency checklist test. Over the next 3 months, one group was then trained using simulator education, while the other continued traditional education. They then completed a second ACLS checklist. Then after the second test, they did a crossover study where the traditional group completed simulated training before both groups took a third checklist score test. Here are the results. The group who received simulation first is in red, group A, and the group who received simulation at crossover is in gold, group B. Prior to randomization, every resident was about equal on the checklist scores, as we can see in the first column. But during the follow-up assessment, the simulation group had significantly higher scores seen in this middle column. The control group was able to obtain similar scores after crossover with simulation about 6 months later, seen in that third column. This is also important to note how even after crossover or 6 months out from the original training, Group A maintained their skills very similarly to their scores seen at that secondary assessment in the middle. And in the end, the gold group was able to catch up when they received simulation training. Further studies have shown that simulation-based education improves quality of care during the management of cardiac arrest at the bedside. And so that actually takes the results of this checklist study and shows that simulation does impact actual patient care as well. Another study in 2010 at Northwestern attempted to focus outside ACLS response and instead evaluate critical care skills at the bedside. They randomized 60 first-year residents to either simulator training or traditional training in preparation of their MICU month. The simulator-trained residents had a 4-hour simulation-based education that included circulatory shock, respiratory failure, and mechanical ventilation. They were then evaluated during their MICU rotation using a 14-item checklist regarding respiratory mechanics, ventilator settings, and circulatory parameters. Simulator-trained residents scored 82.5% on the bedside assessment, whereas traditionally trained residents scored only 74.8%. This was a significant difference with a p-value of 0.02. But you could say that a resident would learn these skills over the course of their 3-year residency anyway, right? PG1 here would still be able to develop the similar skills needed by the time they graduate 3 years later. Why invest in a simulation training program if the residents would graduate with the same skills using just a longer model? Fortunately for us, Northwestern asked the same question in a follow-up study in 2011. This PG1's critical care skills were compared to PG3's critical care skills at the end of a 4-week MICU rotation. However, the intervention was that the first-year residents completed a 4-hour simulation education during the first 3 months of their intern year, with a follow-up 30-minute small group review during the first week of their MICU month. At the end of the MICU month, both groups were assessed using a clinical skills assessment at the bedside of a patient requiring mechanical ventilation. The traditionally trained third-year residents scored 80.9% on the bedside assessment, whereas the simulator-trained first-year residents scored significantly higher, 91.3% on the bedside assessment. And this was despite that the third years had on average 15 more weeks of direct experience in the ICU. This was another significant result with a p-value of less than 0.001. This proves that simulators do enhance learning significantly and can help standardize the lessons learned amongst residents who may receive a range or variety of clinical experiences. But how does this translate to actual patient care? There are studies that show improved adherence to ACLS checklists during real patient code blue scenarios following simulation training. But are other areas of patient care impacted by simulation as well? A study found that simulation-based mastery learning reduced complications during central venous catheter insertion in the medical ICU. 27 residents were traditionally trained and did not receive simulation. They were surveyed regarding complications and procedural self-confidence on actual central venous catheters they had inserted. Then, 76 residents completed simulation-based training for internal jugular and subclavian central venous catheter insertions. This included training videos followed by simulation on a mannequin. The simulator-trained residents were expected to meet or exceed a predetermined passing score of 85% on a skills checklist using a central venous catheter simulator. Additionally, they completed a written pre- and post-test survey. Not only did the simulation groups have improvement in their written examination performance, they also showed fewer complications in actual practice. The historical controls in the simulation residents were surveyed daily during their MICU rotation regarding their central lines. Overall, the simulator group, seen in gold, had significantly fewer complications seen here, such as arterial punctures and need for line adjustments. And overall, the simulator group had a significantly higher success rate of placing their lines compared to the traditionally trained peers. However, a new simulation curriculum, such as in this case, developing a new central line insertion curriculum, does cost money and time, and that could be a barrier to developing new curriculum. However, studies have proven that simulation-based education actually leads to an overall cost savings due to increasing the quality of care and avoiding complications. This 2008 study that I'm about to review evaluated the cost savings regarding avoiding a central line complication in response to simulation-based mastery learning program that I had just mentioned in the previous study. In comparing the incidence of catheter-related bloodstream infections in the year prior to simulation compared to the year following simulation training, there were approximately 9.95 catheter-based infections avoided over the course of that year. Based on a cost model, this saved approximately $82,000 in 14 additional hospital days for each infection avoided. This means a total of $815,000 was saved over the course of that year. And as a reminder, this was in 2008. The estimated annual cost of developing the simulation-based education was about $112,000. This amount is actually predicted to decrease in subsequent years when all you're requiring is the maintenance phase rather than new curriculum development. But overall, this estimated first year cost, or this overall estimate of this first year, saved $700,000 for the health system just based on avoiding complication rates by adequately training residents using a simulation-based education. This exemplifies just how the cost of education is actually easily outweighed by the return on benefits. So, in summary, why should we invest in simulation? Trainees feel inadequately prepared in our traditional model, as we saw in that first survey. Simulation is proven to enhance our clinical knowledge and the clinical knowledge of our trainees. Simulation improves confidence among the learners. And simulation is actually proven to enhance patient safety and cost-effective care. So now that we know that it works, where should we be putting our investment? Where should we be putting our time in creating simulation education? Here's a list of common areas that studies have shown benefits to simulation, and we'll go over some of them in detail. One of the most common situations is the acute medical situation simulation. This allows trainees to practice their responses to rapid responses, codes, allergic reactions, aggressive patients even, and allows them to prepare for that event if it were to arise in their course of practice. Procedures is another common area of simulation, again, for the reasons provided of enhancing patient safety as well as improving outcomes. The most common procedures practiced are central venous catheter insertion, arterial line placement, lumbar punctures, joint arthrocenteses, and thoracentesis. Additionally, we have many communication-based skills that are practiced with standardized patients, including goals of care conversations, family meetings, shared decision-making, breaking bad news, and even handoffs among teams. Telehealth is a relatively new use of simulation and combines a combination of a simulated electronic health record and standardized patients to help learners practice the effective use of telehealth. And then we additionally have POCUS. UW is very good at utilizing POCUS simulation, where our learners are actually able to practice their skills bedside to improve their diagnostic capabilities. This review article actually listed various areas where they felt that internal medicine should be investing time in simulation education. I want us to focus on the area I outlined in red, which focused on the procedural section of common internal medicine procedures. Most of the ones we've discussed so far are listed here in ones that internal medicine providers would be required to perform on a more regular basis, but may not get enough time during training, depending on what their schedule looks like. One thing to note here is that they actually did not include paracentesis on this list, and that is another very common procedure that we run into. So we've already addressed how simulation has improved outcomes in teaching and the placement of a central venous catheter insertion. However, further studies actually do go on to evaluate each of these other individual procedures too, and how the fact that simulation is efficacious at improving the teaching of procedures such as shoulder injunctions, knee injunctions, thoracentesis, and even pelvic exams, and that these would be considered worth investing in the future. Additional areas to consider are the communication skills required by internal medicine providers. In this case, goals of care training. In this 2016 study of 84 PG2 residents, they were paired up to have simulated goals of care conversation with a standardized patient who had end-stage heart failure, and actually also had a standardized family member present too for part of the conversation. The simulation included a brief didactic between two of the simulation scenarios, which helped to educate learners about hospice and communication strategies. It was followed by a post-session debrief to formulate main takeaways. And then at least 3 months later, the residents were invited to identify a patient under their actual care to have a real assessment of these skills. Overall, 90%, as we can see in this red box, I should say, 90% post-survey responders felt more prepared to conduct goals of care conversations after simulation compared to only 42% prior. Additionally, 80% reported confidence in discussing goals of care compared to 67% prior. And these tests were durable at 12 months later that we can see in that blue box. During the real patient session that happened 3 months after simulation, the resident skills were assessed and evaluated to be the same or even improved when speaking with the real patient and family member compared to the simulation. More than 70% demonstrated improvement in ensuring patients' comfort, displaying empathy, and recognizing responding to emotions. Almost all of the patients and families reported feeling heard and satisfied with the conversation. Another example of communication-based simulation would be handoff training. In this study, they followed 225 interns over a 3-year period. They started during the interns orientation boot camp, where they completed a 20-minute large group didactic session on handoff training. They completed then a 30-minute breakout session with a small group where they discussed 3 case scenarios, and then ended with a one-on-one handoff simulation for 15 minutes, where they received direct feedback from a faculty or senior resident on their handoff skills. Throughout the year, these interns then had direct observation and feedback with faculty. The results were pretty outstanding, actually. Here they are with the dark bar representing the results after boot camp and the dashed line showing prior. All interns over a 3-year period showed improvement compared to the evaluations prior in terms of comfort level with providing effective handoffs, confidence with using a standardized tool for handoffs, and confidence in identifying factors essential to an effective verbal handoff. Note that one limitation to this study and a few other studies we've discussed is that it does not always include a true control group and instead relies on historical control groups. And finally, regarding communication training, I wanted to touch on how simulation can be used for telehealth. 56 residents in this study participated in a 3-part, 5-week course in the use of telehealth to manage complex primary care. Of course, this was developed during the time of COVID pandemic and the rise of telehealth use kind of nationwide. In session 1, they conducted standardized patient interviews using telehealth technology. For the 5 weeks after this session 1, they coordinated care via e-messaging with a simulated patient. And then in session 2, they led a simulated interdisciplinary teleconference with surveys measuring confidence levels of the trainees before session 1, after session 1, and post session 2. Additionally, the standardized patients they interacted with completed checklists, and the investigators directly assessed the different e-messages that were sent by the trainees. Overall, a significant number of residents felt more confident or even very confident with critical telehealth tasks following the simulation training. This included an effective use of the camera, effectively communicating remotely with patients, effectively troubleshooting technology issues that would arise during patient visits, counseling patients remotely, and even building that rapport via telehealth, which is sometimes one of the most challenging aspects of telemedicine. By the end of this, 92% of residents reported wanting to undergo additional telemedicine training moving forward. So this all being said, now that we know that simulation has been shown to help in all these different domains, how does this apply to us? What does UW currently do to incorporate simulation? Actually, we do quite a good job already, as you can see here. Anything outlined in red are different areas of simulation that we already incorporate in some way during our residency training. Acute medical situations, procedures, physical examination, goals of care conversations, breaking bad news, and even POCUS. Here's a current example of what our UW simulation curriculum looks like at present. Notice how many different simulations are present in the intern year to help build that foundation for ongoing practice moving forward. During the fall, acute situations is a session where 2 short simulations take place for the interns to practice responding to a rapid response situation. The CVC placement is a mastery-based model similar to that study from Northwestern I discussed, which requires a resident to complete a simulation with a predetermined threshold score before being allowed to place central lines on patients. The PAP and pelvis workshop helps interns prepare for sensitive physical examinations using standardized patients. The geriatrics OSCE, or another in the long form is observed structured clinical experience, takes place during each intern's geriatric rotation, sometime during their intern year, but for simplicity's sake, I did put it as an example in winter here. Credit to Dr. Barzi and Dr. Chapman in the geriatrics department for creating this opportunity and continuing it for all of our interns. POCUS is a short didactic and hands-on session where interns practice using an ultrasound on a simulator and even standardized patients to help improve their ability to evaluate diagnostics bedside. The intern mock code takes place right at the end of the year in the simulation center, where interns work as a team and rotate through the various roles of the code response team. Then as seniors, we have we do still have some opportunities, but they are much more sparse to be available to our residents. The interprofessional mock code is coordinated by Dr. Holland and takes place sometime during the PG2 or PG3 year, and has a senior resident take the role of a code leader alongside pharmacy residents and nursing students to work on interprofessional communication and further their ACLS skills practice. The We Talk session is coordinated by a number of people, including Dr. Zielinski and Dr. Campbell, and takes place sometime during the PG2 or PG3 year. It involves a senior resident practicing empathy and communication of bad news or goals of care to standardized patients. I think this is a fantastic use of simulation in our curriculum overall, and we can see how the simulation is utilized heavily early in residency to help provide that foundation for further training and practice before addressing even more difficult situations and focusing on complex communication skills as a senior resident. This really highlights that use of a mastery-based education model. Based on the studies we've reviewed this morning, I still think that there is room to continue adding simulation education to enhance that mastery-based education. But how do you actually build a new curriculum or a new simulation session? There are 5 or maybe 4, depending on the person you ask, main steps to creating a new simulation session. Step 1 is the preparation phase. This takes many hours of writing, editing, and discussing the exact details of the cases and setup of the room that you'd like to use. You create goals and teaching points, and then you meet with the simulation staff to work out details and make sure everyone is available for your session. The Simulation Center is very busy, but are willing to work with you on finding time for your learning sessions. And additionally, as a joint venture between UW Health and SMPH, IM resident simulation sessions are free to run unless disposable materials or standardized patients are needed. Step 2 is the pre-briefing session. You take the participants to a room to introduce them to what they're about to participate in. They should receive any important information regarding fidelity to the situation that will take place in the room, what they will have available in the general setting. They should also be reminded of the simulation agreement, which comes in 2 main parts, including confidentiality about the session, which helps create a safe learning environment for everyone, and 2, the suspension of disbelief to really allow everyone to get the most out of the simulation session. 3, we have the simulation scenario. Participants complete the simulation itself with facilitators adjusting the simulation as needed for the participants to get the most out of the time they spend or to complete enough checklist items or certain criteria that would end the simulation. Afterwards, we have one of the most important aspects of simulation, which is debriefing. This is the period of time after each individual simulation where the participants are asked to reflect on their performance, what they learned from the simulation. Facilitators of debriefing are mostly there just to ask conversation prompts or reflective questions regarding performance, emotions, what went well, what can be improved on. And usually there might be a very short didactic takeaway from the case, such as a correct use of transcutaneous pacing or recognizing an important POCUS finding. Sometimes video recordings are even used in this case for everyone to review their own actions, or sometimes it's just simply a discussion. And then finally, the fifth step is the analysis phase, where you go back and look at what actually everyone took away from the session. Did you meet your goals? Were there any other recommendations for further improvement? And then hopefully you can adjust your simulation session for each kind of further use of it. So this year, I actually had the opportunity to see this firsthand, like I mentioned in my introduction. I was able to work with Dr. Alex Wick in hospital medicine, who has a lot of experience creating and facilitating simulation curriculum. Additionally, I worked alongside one of the rising chief residents, Dr. John Davis, in helping to create and implement a brand new piece of simulation curriculum. Our goal was to create a next step to that intern acute situations. These would be more complicated scenarios and at the senior resident level in terms of diagnostic challenge and or therapeutic needs of the patient. Therefore, in step one preparation of our simulation, we created our plan to target this to mid-year PGY2 residents and hopefully use PGY3 residents as instructors or facilitators. I'll talk more about the use of other learners as facilitators in a minute. The residents would enhance their teamwork skills by working in groups of 4 and complete 2 different complicated acute situations. This would then be assessed using pre and post test surveys during the pilot. Our additional goals included improving the residents' comfort using POCUS to assess a rapid response and increasing the practice of ACLS management, practice of implementing post-ROS cares per the ACLS algorithm as well, since usually residents don't do this independently and do have some support, although that experience does vary among different residents. So kind of continuing through our step one, we have this simulation planning with the sim center itself. Again, it took many hours to really set up. And in the end, we decided to use a clinical simulation room and high fidelity mannequin. Additionally, we decided to use a POCUS simulator with findings found on it that are consistent with the patient's presentation that can help either rule in or rule out certain different differential diagnoses. We focused on PGY2s, although for the pilot, we were open to any senior level participant just based on availability. And we acted as the facilitators for the pilot study. Dr. Wick was able to take this plan to the Sim Center to set up the dates and make sure we had personnel available. Then in step 2, we did the pre-briefing where we did have the participants meet us in a room and we discussed what each session was about to entail. Then we actually got to run the simulation scenario itself in step 3. So this is an actual picture from our mock code pilot just last Friday. So 8 PGY2s and 3s completed 2 different complicated acute situations over the course of 1.5 hours. High fidelity mannequin was used in a POCUS simulator, as you may be able to see through the window. Here you can see Dr. John Davis actually in the control room and then the group of residents working through the simulation beyond the 2-way mirror. We then would debrief in a separate room, asking residents for how they think it went, what they did well, and what they want to learn more about or improve upon. They were asked to share one main takeaway from each simulation. And then we got to step 5 of the analysis. Although because this was a pilot program and only being run for the first time last week, the results are very preliminary. Overall, we saw the following trends. We saw an increase in comfort leading code blue teams, an increase in comfort using POCUS during rapid responses, an increase in, or actually, sorry, not an increase, but they all felt that the simulation was a valuable experience to their learning. And all the residents felt that working as a small group was a valuable experience compared to working alone. And so then taking that step 5 into next steps and where should mock code 201 go next? We should formally review the results, adjust the simulations based on those results, as well as any other feedback and goals that we had asked for the residents to assess on their post surveys. And then the next step will be to distribute this to all the residents, schedule PGY2s next winter, and train the PGY3s as facilitators. So that was a good transition into where we should go next. We have this new pilot program, and now how does this kind of fit into how we should continue to expand our simulation curriculum to pursue that goal of an extensive mastery-based education model? Here's what the next generation UW simulation curriculum would look like after adding in that mock code 201. Again, hoping that it would take place during the winter of PGY2 year, with PGY3s being able to lead that mock code during their own winter of their third year. Currently, PGY2s actually help to debrief the intern acute situations, and studies show that near-peer facilitators, such as using a resident learner as the facilitator instead of faculty, actually do have similar quality of assessment in the debriefing and facilitates team familiarity between the classes, and finally results in high learner satisfaction scores compared to using faculty mentors. An additional benefit is creating, again, a more welcome and safe environment where residents do feel more comfortable sharing their experiences, discussing where they'd like to improve or what they would like to know, compared to when they sometimes work with faculty where there might be more intimidation. This has been utilized at many institutions, but in one study, the participants who worked with their own senior residents as facilitators were so happy that they requested the voluntary training session to be mandatory for everyone. Now, here's where I would consider adding in even additional courses over the next few years. The reason I included additional procedures, especially during intern years, such as joint injections and lumbar punctures, is because residents do not always have the same opportunities available to do procedures and variable levels of training depending on how they have the opportunity. More and more often, the dedicated procedures team performs daytime procedures such as thoracentesis, lumbar puncture, paracentesis, which is reasonable due to the limited amount of time for the daytime medicine residents to actually perform the procedures. And it also allows the procedure resident, which is a resident on elective, to practice repetitively over their 2-week rotation on the service. However, this is a one-time rotation, which does over the course of all 3 years, which does not lend itself to longitudinal repetitive practice. Intentional repetitive practice is a fundamental aspect of simulation training. And by having exposure during a simulation curriculum early on, residents have been shown to feel more confident performing procedures overnight or even during the day when the procedures team is unavailable. This leads to repetitive practice, increased levels of self-efficacy, and increased efficiency during the procedures, rather than always asking for a referral. Additionally, decreasing the number of procedure referrals has actually been studied as a way to reduce costs and has shown some benefit in institutions. In regards to telehealth, I've shown you the results that other institutions have obtained regarding improvement in telehealth effectiveness and confidence using simulation curriculum. It's here to stay, and so we do need to start addressing its best use head on and develop a specific curriculum for residents to understand its best use and practices. Goals of Care and Breaking Bad News is currently integrated into the We Talk sessions that I had mentioned previously. It's a great way to practice these complex communication skills in a setting that is safe and you can receive feedback from a standardized patient. And I even propose adding a disclosing medical errors simulation in the PGY3 year to further expand on the complex communication skills developed in the We Talk sessions. There's already some evidence regarding how effective simulation is for those types of simulation or situations, such as disclosing a medical error. And I propose it could even be combined with almost like a full-length walkthrough situation where you are attempting to place a central venous catheter and you accidentally have an arterial stick. During this simulation, you would then go into how you address this error acutely during the procedure, and then follow up directly by practice disclosing this error to the standardized patient or standardized family member. While the idea of simulation is to reduce the number of errors that happen, they are inevitable, in making sure that our residents are well prepared on how the most effective way to address them in the future is paramount. Acute Situations 301 would continue to advance the skills that residents need to know how to quickly and effectively address, but may rarely encounter or may never encounter during their training. This would kind of be an advanced or kind of building upon in acute situations as an intern, mock code 201 as a second year, and then now you would perform an even more specific management as a PGY3. Examples that I came up with would include basic ventilator management, transcutaneous pacing, acute seizure management, or even work with de-escalating an aggressive patient or family member. All of these additions may seem like a large jump, and I completely understand that. I'd propose that the program works up to this over the next few years, adding a new session each year and focusing on making each one exactly what we need it to be. Additionally, time requirements are one of the large barriers to initiating new simulation. It requires the time from the simulation center, which is busy providing training for a variety of groups. It also requires time from the educators and faculty. And finally, it requires time from the residents. As a senior scheduler this year, I completely understand and am aware of how much time is already asked of residents, and I do not think we should be asking for more time taken away from their training to focus on these simulations. However, the residency is moving to this new X+Y model this summer. And as part of this model, there is scheduling work to protect academic days during 2 weeks out of every 8 weeks. This means that some of these academic days during the ambulatory blocks could include a simulation session where residents would not need to be pulled away from career-oriented electives, research time, or inpatient training. This also would help with team continuity on inpatient training experiences. I think that the X+Y model will be of extraordinary benefit to future residents and to future curriculum endeavors. Simulation-based education is a goldmine of research questions and projects for anyone. These projects also have the potential of being completed by residents during the short span of their 3-year training. Here are some of the ideas I had for further work that including evaluating the specific needs of UW-IM residents so that then we can tailor the training program and the simulations to those needs. Evaluating the UW simulation impact on the training outcomes then and how effective it is at training residents. Then taking that a step further to determine its impact on patient care. More work in general needs to be done on determining the exact interval and that's most optimal between the training situations to create the best learning environment and most prolonged or durable education benefits. Additional work also still needs to be done generally on determining the optimal amount of time spent in simulation versus time spent with didactics and determining the best ratio for this. And finally, we can do our own cost simulations here, determining how much our simulation curriculum is costing versus how much we're saving based on its outcomes, which would only continue to encourage its use moving forward. So finally, in conclusion, I just want to summarize 4 main takeaway points that I hope you take from this presentation. Simulation is proven effective in many different domains: communication skills, procedures, responding to rapid responses. And our UW-IM residents currently report significant benefit from the current simulation that we have. However, as I've outlined, the UW-IM residency should continue to utilize simulation while continuing to build this mastery-based curriculum. It's a great curriculum that we have currently, and I think that we can even make it even better for years to come. And finally, as a further incentive, many simulation-based med-ed research opportunities exist that could be completed by residents and faculty and continue to add to our literature base and networking nationwide. I want to thank all of you for coming to listen to this today or staying home and listening to it virtually. I also want to specifically thank a few people who helped to prepare this grand rounds, specifically Dr. Holland, who helped to review the presentation and content, and also being my chief year mentor over this last year, Dr. Smith for helping to prepare the presentation, and also his mentorship last summer while he was the interim program director and I started my very first few months as UW chief. I want to thank Clint Thayer for providing my title picture, as well as some pictures throughout, and technology help today. thank Dr. Alex Wick for her mentorship, learning to create new simulation curriculum this year, as well as Dr. John Davis and his role in that project. And the Simulation Center staff themselves are wonderful people and extremely knowledgeable. And I couldn't have done any of this without their excellent training over the years and help creating simulation this year. Within the Department of Medicine, just regards to my entire chief year, I had to take time to thank Dr. Andy Coyle for his guidance and mentorship after he started as program director, Dr. Lynn Schnapp for her frequent mentorship since 2020, and the APD and residency program office teams for all of their support this year and really providing a good education to me regarding academic medicine. It's very bittersweet for me to leave Madison and the UW Department of Medicine this summer to continue fellowship. And I'd really like to thank all of these people for helping make residency and chief year an outstanding experience. It'll be really tough to say goodbye. And it'll be especially tough to say goodbye to my co-chiefs, Nimrod, Lindsay, and Emily. I've learned so much from each of you working with you this year and seeing all of your accomplishments. Thank you so much for all of your hard work. And I definitely would not be able to have given this presentation or learned so much this year without all three of you. I think we make a wonderful team, and I'm so excited to see where each of your careers go in the future. Thanks again, and I'm going to miss all of you next year. And with that, I'll open the floor to any questions with any remaining time I have.
Wonderful. Thanks, Scott, for an outstanding presentation. We are so proud of all you've done. We're sad to see you leave UW, but I guess the recruitment process for faculty begins now for 3 years from now. So hopefully we'll see you back at UW again someday. So really, I think a terrific presentation and an outstanding call to action for us. I think a lot of learning and residency happens in the clinical domain, but what we control in curriculum, didactic, simulation. I think here, as everywhere, simulation is less than 1% of all total curricular time, and it's really the one space in sort of IM education where we've seen evidence of patient level positive outcomes. And so I think a great call to action to continue our shift towards active learning. I see a couple questions in the chat. Maybe I'll start with one of my own. So I think one core value of this program has been and will continue to be individualization of training. What do you see as sort of the opportunities for individualization of simulation training for residents in the future?
I think that's a great idea, specifically regarding that mastery-based education model too. Again, the tenet of it is the fact that you complete a certain threshold or checklist, or else you do need, I don't mean to say or else as a threat, but or else you need to continue going on with kind of further review or maybe even change up the way you were learning before to continue that process. And so although the time requirement would be a lot, I think it would need kind of almost like a specific faculty member or a specific mentorship APD to kind of focus on the needs of each resident. But I do think it's essential that we customize it to each resident, both in terms of making sure to meet minimal thresholds, but then also even like individual goals, such as practicing specifically, if you're interested in going into hematology oncology, you can discuss more of those benefits and risks of different chemotherapy agents and actually practice that on a simulated patient before going into that field. Again, the main limit there would just be time and availability, but I completely think it would be worth it. And the studies would be interesting to see too, how that actually works.
Great, thanks, Scott. I think a couple of great questions in the chat. I think one comment from Dr. Siraj about some simulation work they've done in global health with some interesting and promising early results. I think simulation everywhere is great. And I think lots of opportunities for collaboration between programs and different institutes. A question from Bob Woodson in the chat. Is there any simulation type work on improving handoffs of patients from hospital teams back to PCPs at discharge and preventing readmissions?
That is a great question. And I am not personally aware of anything in the literature, although I did not investigate that. I did not investigate that question specifically. So unfortunately, I can't answer that. But if the answer is no, then it's definitely a place, again, add that to the list of potential future directions of this.
Great. And then a question from Laura Zakowski in the chat as well, asking, is there data showing that sort of like high fidelity simulation has better outcomes as compared to things like role play for topics like goals of care, breaking bad news, things like that?
So I cannot cite a specific study, although I will note that most studies have built upon the idea of really kind of using that immersion-based and high fidelity models. specifically when it comes to communication too. Knowing that you're talking to at least what feels like a standardized patient or other patient rather than someone who might be your superior within the hierarchy of academic medicine does show higher levels of confidence following and making sure that they actually received like a kind of appropriate feedback compared to just role playing between people who are not paid actors or paid standardized patients. That being said, even low fidelity simulation models, though, for procedural skills, even if it doesn't even look like a patient, but it's just the act of fine motor skills, has shown equal benefit.
Great. So we are right at 9. So I want to thank Scott again for an outstanding presentation, outstanding work as a resident and chief resident, and thanks to everyone for attending today's Grand Rounds.
Thank you, everyone.